Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In order to prevent the spread of the virus, we all need to do our part. One of the easiest ways to prevent that is by wearing a mask. In order for a mask to do its job, it needs to cover your nose, your mouth, and your chin. First, you should wash your hands with either sanitizer or soap and water before putting on a mask. Then pick up your mask by one of the ear loops to make sure that there's no tears or stains on the mask. If it is dirty, throw it away immediately. If it's intact, take both loops and put it over your ears like this, and then press down on the bridge of the nose to make sure that it fits and there are no gaps. Once you are done with the mask, please take it off the same way. Both ear loops, pull it away, and put it either in a Ziploc bag or throw it away if it's a surgical mask. If it's a cloth mask, make sure to wash it with soap and water and keep it dry for the next use. Do not put your mask down at your chin or above on your forehead when you're starting to remove it, as that just contaminates the mask. Thank you so much for doing your part to prevent the spread throughout the city.
El Paso Physician, and we are in a spike period of COVID-19 here in October of 2020. We want to remind everyone to absolutely please wear your masks. Some people say it's hard to talk, it's hard to have conversations. We're going to have an hour-long conversation between the three of us with our masks on, protecting not only ourselves, but those around us. Also, we also know that this is election year. The last presidential debate is going on as we speak. And I wanted to let you know that PBS El Paso will be airing that debate starting at 8 o'clock, so right after this show. This show is from 7 o'clock to 8 o'clock. PBS El Paso will then air the presidential debate, the last presidential debate before the election, at 8 o'clock this evening going forward. So, all that being said, let's now get to our topic. We all know children. Some of us have children. Some of us have grandchildren, great-grandchildren. We just think that they're little human beings, right? That's not necessarily the case when it comes to medical care. Kids have different emergencies at different ages, and there are also ongoing conditions that children have to do and have to be treated for even during this time of COVID. We are here this evening to discuss how to best handle common and not so common childhood medical issues, and specifically this evening, cardiac issues. What's the best course of action to treat those little ones during this time of COVID, and also, when do they need to go to the emergency room pronto? As you know, this is a live program, and think of questions of your own to call us with. The number is 881-0013. This program is underwritten by the El Paso Children's Hospital, which opened its doors in 2012, and it has helped decrease pediatric patients leaving our area by 85%. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing their medical students every single month, week, year when we're around here. We appreciate it very much. And when you call your questions in, one of these students will be taking the questions and then filtering them our way. And always, the El Paso County Medical Society for bringing this program to you each and every month. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. With me this evening, we have two pediatric cardiology specialists. We have Dr. Shweeny, as he says he is so lovingly called by some of his colleagues and family, Shweeny Bagduga. Bagadu. And also he is the El Paso Children's Hospital Pediatric Intensive Care Unit Specialist as well, along with a pediatric cardiologist and critical care specialist. Then we have Dr. Jeffrey Schuster, and the last time Jeffrey was here, Dr. Schuster was here, he said, yeah, I've been here before, and I said, I can tell you exactly when you've been here. I lovingly keep all of these scripts for years and years and years in case for some reason I don't get answers or questions. February of 2006 is the last time Dr. Schuster was here, and it was a pediatric cardiology program at that time. And he is the Chief Medical Officer at the El Paso Children's Hospital. So, gentlemen, thank you so much for being here. I appreciate it very much. The debate is going on, but again, if you're not recording it, those of you that are watching the show will be able to watch it directly after this program. Dr. Baduga, If I could have you explain to the audience at home what your day-to-day goings are right now, a little bit different with the time of COVID, but not so different. But that way, as the show rolls on and people have questions to ask, they kind of know which doctor to ask them from, or they'll just shoot questions our way and I'll know who to ask them from. But what is we talked about your title, but what about your all day, every day?
So as you said, I'm a trained pediatric cardiologist and intensive care specialist. Depending on my schedule, either I'm in the clinic taking care of cardiology patients or in the intensive care unit taking care of sick patients, not necessarily cardiac patients.
Okay.
When I'm in the clinic, we are still seeing patients taking all the precautions. We have a screening procedure for the patients and the family where we ask all the needed questions to screen patients who might have gotten COVID infections, and we take the temperatures, and if they are able to be seen by the cardiologist in clinic, we'll go ahead and see them.
Okay.
These patients include the regular new consultations, as our pediatricians refer them, or people with existing cardiac diseases that are already receiving cardiac care.
Right. And we're going to go through those two different types of conditions this evening, because I think that when you hear about pediatric cardiology, it seems that there's congenital, you're born with it, or things that happen later on in life. So we're going to kind of separate those two for the audience in a little bit, and then kind of go through from there. Dr. Schuster, I want to say this to the audience because I find myself doing it. And if you feel that your mask is falling off, wear your mask, number one. If you feel like it's falling down, especially when you're talking, the worst thing you can do is take your fingers on the top and touch your face and touch your nose and pull it up from there. The best thing to do, Dr. Days, I'm not sure if she included that in the video or not, is take it from the bottom, a place that you would not be touching your skin, and pull it up a little bit over your nose. The whole mask will go a little bit with it, because I know we all tend to do that, and then we grab from there. So that was something that we also were asked to give to the audience. So on that side note, Dr. Schuster, I feel like 2020 is all full of side notes, right?
Yes.
Goodness gracious. So from 2006 to now, what's different in your job? What are you doing all day, every day? You are chief medical officer now, but still you get to treat patients and talk to people and do your all day, every day good stuff.
The hospital duties are kind of on top of everything else I do. The still seeing patients in the office on a regular basis, and like Dr. Badugu, seeing new consultations, follow-up patients, patients who are waiting for surgery, patients who've had surgery, and things like that. So it's a broad mix of kids that we're seeing.
And when you say a broad mix too, you talked a little bit about it, Dr. Badugu. I'm going to say that. You know what? You should give me it's hard when you can't see the whole face, because sometimes you can't see the stinky eye coming out. But I would like to, before we get into a lot of these questions, because we are in a spike of COVID time right now, you started with it, but I'd like for you to explain to the audience that when people do need to come to the hospital, that there are precautions in place. And if you can kind of walk through what people are to expect so that there is a bit more of a calmness versus people having issues at home and not wanting to go to the hospital because they're scared to go out. So we want to make sure there's a balance between the two. And like I said, you started on it beautifully earlier, if you can continue going to that.
Absolutely. In the clinic, we're going through these screening questions. We ask the family members if they have been exposed to anybody with signs and symptoms suggestive of COVID infection, if they have any symptoms suggestive of COVID infection, if they have fevers, and we check the temperature of the family members coming along with kids. And once they meet all the criteria, we go ahead and see them.
Okay.
Because we don't want other clinic staff and other children that are coming to the clinic to be exposed to this virus. In the hospital, we have a very fancy way of measuring temperatures right at the entrance in Children's Hospital. And they get screened. Of course, they'll go through all the questionnaire, and they'll get their temperatures checked at the entrance in itself.
Okay.
So that we keep all the all the kids who are in the hospital and all the staff who are in the hospital safe, and people who are in emergency situations, they would go through to the emergency room and they would be appropriately triaged, and if they have signs and symptoms suggestive of COVID infection, they'll be appropriately taken care. And if they do not, they will be given the appropriate care and the specialized care that they need depending on their necessities.
Okay.
So we're trying to make sure that we keep everybody safe, including the families and children who need medical care, and already people who are already in the hospital needing specialized care.
Okay. Nicely explained, and I know that as Chief Medical Director, this is something that you're keeping on the staff with all the time as well. And number one, thank you from everyone who's not in the medical community but always still needs to get some kind of work done. We have a graph of the heart. What I'd like to do, and it may seem so simple to you guys because you're cardiologists. However, I would love, Dr. Schuster, if we can just in a way talk about what the heart does. We've got 4 chambers. We've got the top chambers, the bottom chambers. We've got red blood. We've got blue blood. We have all of this. There is a chart that we have on a PowerPoint that might be able to be pulled up. If not, if you can kind of talk through the chambers, because as we're talking about congenital different issues, because that's really where the functions of the heart comes in. Later, as you're grown up, then issues are a little bit different because there's lifestyles that come into effect, et cetera. So if you can kind of explain the functions of the heart.
So when I commonly do this, I start by pointing at my hand because I have this vein that nurses lust after. They want to put an IV in it because it's so big. But it's bluish.
Right.
And you've got bluish blood in your veins, and you're coming to a bigger vein, to a bigger vein, to one big vein coming into the right side of your heart. Same thing in your feet coming up. There's one big vein coming up into the right side of your heart. That's bluish blood. It's been out to the body, it's delivered its oxygen, it's delivered its nutrients. Now it's on the way back to the heart. Comes to the right atrium, the right upper chamber, through the tricuspid valve into the right ventricle, which is a pump. And this pump pumps all that bluish blood out to the lungs where you're having breathing and oxygen. Blood turns bright red, comes back to the left atrium through a valve, the mitral valve into the left ventricle, which then ejects it out to the body and delivers its oxygen and nutrients again.
And I like that. It's when people look at graphs and they look at different things, either on the internet or something, because they'll see the red and they'll see the blue. And very rarely do we explain what that means. So I just wanted to have that, something that was out there. Dr. Badugu, I'd like to talk with you. I know we started a little bit about the 2 different types of heart conditions that children usually have. And one is congenital, something that they're born with, something that's an issue within the heart. And then there's ones that happen later with accidents. I'd like for you to focus first on some congenital heart conditions of little ones. And sometimes you don't find out until a couple of years later. Because I know reading through the research here, it shows that there should be blood pressure taken on children as early as 3 years old and pretty regularly therefrom.
Right.
So maybe we can discuss that as well.
Yeah. As a group, congenital heart defects are the most common problems encountered by children in United States. The incidence, if we say, we have approximately for every 100 kids, we have 1 kid that could be born with congenital heart defects. And 1/3 of these patients that are born with congenital heart defects is what we call as a critical congenital heart defect, meaning that they would need some intervention, might be surgery, might be a catheterization in the first month of life.
Okay.
And these are what we call as critical congenital heart defects. There are certain other congenital heart defects that are not so critical, that present in the first few months to years of life, but still nevertheless need an intervention for kids to grow normally. In El Paso, even though this is one of the largest cities in the United States, we still do not have all the facilities to take care of these patients here in El Paso. So at this point of time, all the newborns that need any intervention or surgeries within the first month of life, so-called critical congenital heart defects, they're going out of town, either to San Antonio or to Dallas or Houston, depending on the type of procedures that they need. The other type of heart defects that are not so critical, that present later on in life with either murmurs, with bluish discoloration, with failure to grow properly, those are the kids that we usually find and diagnose in the office. Some of these kids were just starting to do certain procedures, not necessarily cardiac surgeries, but interventional procedures like plugging the holes in the heart, like ASDs, closing the extra vessels around the heart, like the patent ductus arteriosus. We're able to offer them in El Paso in itself. And this is something that we are building slowly. And eventually, with Dr. Schuster, El Paso Children's Hospital, and Dr. Mulukutla, the interventional cardiologist, our goal is to prevent out migration of all these situations, of all these kids who have heart defects, because I see, I'm a cardiac intensivist and I work in cardiac ICU in San Antonio as well. And sometimes it's not uncommon to take care of kids from El Paso in San Antonio. And there are certain types of heart defects that are very difficult to manage. Kids need multiple surgeries, and it's not unusual for the families to be living in the hospital for months.
Wow.
And as a pediatric cardiology group in El Paso, our aim is to see a day where all these kids can be taken care in El Paso itself.
And that's the ultimate goal. I said at the beginning of the show that overall pediatric care has improved, 85% less kids leaving for pediatric care, but cardiac care, we've got about 60% of the children that are still leaving the market. But I say a but to that because every day that is decreasing as far as the people that are leaving. And Dr. Schuster, I'd love for you to kind of take it away here as the Chief Medical Director.
Well, so
the
I
things
did
that have been
want
put in
to
place.
say
Yes.
that nowadays we can frequently diagnose those critically ill babies before birth.
Great.
So
Okay.
fetal echocardiography, which means you're having a cardiologist look at the baby before birth, we can find things that can be extremely important. Now, if you diagnose, for instance, a large hole in the heart, that baby's going to be born in El Paso, taken care of in El Paso, but then we'll need surgery somewhere else at this point. But there's another factor to this. If we have a baby before birth that we identify that this baby is going to be critically ill at birth, then it's much better to have identified that baby and have them deliver where they can actually do something. I had one patient who had a terrible aortic stenosis that they delivered by C-section in Dallas in the OR because they thought they were going to take that baby off the mom and into the OR. They didn't have to do that, but it is so much better to know that's coming.
Right.
Because I mean, you don't hear much about SIDS anymore. Maybe it's because we're doing fetal echoes.
Well, you hit on something that to me is always fascinating, especially on little itsy bitsy tiny ones, is diagnosis. Because the only way, they can't tell you.
Yeah.
You know, so when, and I'd love for you to expand a little bit more on this patient, how did the doctors know that the child had something wrong prior to her giving birth? So, you know, was it a simple sonogram that there was something seen? Or to me, the diagnosis of very little ones, fascinates me because how do you know? And I have this laundry list, and you were beautiful when you went to all these diagnostic interventional radiology and all these different, there's MRIs, there's diagnostic x-rays, there's stress tests, how do you do that with the little one, there's EKGs, there's echoes. Just carry me through a couple of case studies of how you see.
Generally speaking, the highest yield, if the OB or the perinatologist, who's the subspecialist OB who takes care of moms with high-risk pregnancies, and that includes if the baby has a heart defect. If they say they think there's something wrong with the heart, there almost always is, and that's by ultrasound.
Okay.
And so if they see something like that, you know, a pediatric cardiologist who does fetal echocardiography will look at that, and really the skill is to know, well, that kid's going to be deathly ill at birth or he's not, and that's what you really want to know. Plus, there's a lot of things you have to do, of course, preparing the family. I love doing fetal echocardiograms when they're normal because the mother gets to go,
Right, no kidding. Yeah.
but it's so important to find the ones that are going to be so sick at birth so that we can salvage that baby, hopefully, rather than having a surprise that can't come back from.
And what are some of the most common defects that you're able to fix? So I know that there's surgery that's performed, not often, but can be performed on a woman who is pregnant. And I don't know if that is heart related. I don't know. What are some of the common procedures that are done on pregnant women to the fetus while she's still pregnant? And I'm veering off a little bit because then I want to also go to what can we do immediately, as you were talking about, right after the baby's born, what is an option?
The interventions that can be done on babies while still in the mom's womb, they are fairly limited at this point of time, and they are all palliative procedures. In certain situations like what we call as a hypoplastic left heart syndrome, which is basically instead of 4 chambers of heart, 2 of those chambers are not completely developed. And it could be because of narrowing of the blood vessels that the blood gets pumped out of the heart. And in certain situations, there have been some experiments where the blood vessels that get pumped out, the blood vessels that the heart pumps blood out to, are perforated so that there is more forward flow into the blood vessels.
So you can go in there and help open those up?
To try and see more blood flow goes into that blood vessels. What it does is more flow causes more growth of these blood vessels and heart chambers, which then, once the babies are born, could be palliated more safely.
Okay.
As I said, these are still very, very difficult procedures that are done only in specialized situations, and the outcome is not as we would expect or as we would hope in these sort of situations, as these are terribly complicated procedures.
Right, right. It's fascinating that it's something that can even be done. I mean, it's amazing to me. Dr. Schuster, I'd like to go with you and talk a little bit about just some of the options for diagnostic intervention that you all have at the hospital, because I'm looking at this laundry list and it's impressive. And if we can now look, to me, I think of stress test. I think of, the 55-year-old guy who's been having a hard time. But again, we're talking about pediatrics here, pediatric cardiology. Is that something that you do or are able to do with children as well?
We're able to do most diagnostic studies here in El Paso. I mean, I've been doing this for 32 years now, and so I learned with chest x-ray and EKG, which are the two very basic tests. And we can still see a patient with those 2 studies and say, there's nothing wrong here, it's okay, you've got an innocent murmur. But if you've got an abnormal EKG, if you've got an abnormal chest x-ray, you're going to need to do more investigations. And usually our next step is echocardiography, ultrasound of the heart. And that shows us information about the anatomy of the heart, and the function of the heart. So we're able to say, well, there's a hole here, or this valve is tight, or things like that, but we can also say, yeah, but the heart's still doing good.
Right.
Or, oh no, the heart is not doing good, and we need to do something much more quickly on that. Now, we've actually been taking some steps to make things even more definitive. For instance, when we're talking about arteries, computerized tomography angiography, or CTA, can really show the arteries going to the lungs, can really show the aorta coursing through the body. And the next step, which is more difficult because it's a much longer study, requires sedation usually to do it, is cardiac magnetic resonance. If you've heard, for instance, I've had 2 MRIs, but cardiac magnetic resonance, you're looking at the heart and the blood vessels. And when I had my MRI on my back wasn't moving 60 times a minute.
Exactly.
So you have to have special technique to be able to look at the heart. But then with CMR, cardiac magnetic resonance, we can see the heart function, we can see the anatomy, we can see the veins and the arteries to a very definitive degree. And so we're very happy about that.
So take me through an MRI of the heart. Like how can you do that if the heart's moving
Well,
so fast and so
you have to have an EKG going.
right?
And then the machine is set up to look at a certain interval of the heart rate.
And in a very small space, I'd imagine,
Yeah,
right? Because you'd have to really zero in
yeah.
on a small amount of space.
You have to be able to look at the same point of every heartbeat, and then you can move through it and get all the different parts to that. But when you're acquiring it, you have to have it all organized so that you're looking at the same thing.
I can imagine.
So it's that's why it takes longer
Yeah.
than a CTA. A CTA can be done literally in minutes.
Right.
But for CMRs, most of the time we have to sedate even adults for that because it might be 45 minutes.
Goodness.
Maybe longer at times.
Right.
But so you really have to have.
But the information that you get,
Oh,
I mean,
can
I didn't even know you could do an MRI of the heart. Not until I was reading through this earlier today. That is fascinating to me. Dr. Badagu, I'd like to go back to you. I joked a little bit about it earlier, but dead serious, that blood pressure in little ones, I don't know when I had my first blood pressure done. You know, maybe when I was pregnant in the hospital with my first child. I don't know.
Right.
But I'd like to talk about family history, because I think that's kind of where we're going with that. If we know that there's a family history, or if we knew that there were issues with mom when she was pregnant, etc. But let's also talk about the general populace as well. Is blood pressure usually taken in a pediatrics office? I don't know. I would just love for you to address that question in any way you'd like to.
Absolutely. It's a very complicated thing. It sounds like a simple blood pressure measurement, but there are many factors that go into children and measuring their blood pressure. On one hand, we have heart defects like coarctation of aorta, where the blood pressure is high, and the blood pressure is higher in arms versus legs. So that simple measurement of blood pressure in children can diagnose those conditions. The other aspect or other complication in measuring blood pressure in children is not many kids enjoy coming to the clinics.
Right, exactly.
Not many kids enjoy getting their blood pressures checked. Not many kids enjoy getting shots. So they're understandably anxious, understandably nervous, and they have high blood pressures in certain situations, which is understandable and normal.
Right.
There are kids who have not just high blood pressure in the clinic setting or in the hospital setting. They tend to have high blood pressures all throughout the day. And these kids are the ones who have a family history of high blood pressure. These kids are ones who have obesity. These kids are the ones who have unhealthy diets in their regular diet. And measuring blood pressure in the office is the beginning of trying to diagnose all these conditions that we talk about. And El Paso is one of the cities where there is a very high incidence of obesity,
Right.
and where there is a very high incidence of high blood pressure, even in younger kids. And as an effort to help patients and families with these situations, pediatricians try to measure the blood pressure in the clinics, and if they notice that the patient is calm but the blood pressures are still very high, that's when they refer these children to cardiologists and nephrologists, heart doctors and kidney doctors. What we do is try and isolate what we call as a white coat hypertension.
That's exactly where I was going to go. Exactly. So what I'd like to do, so people who go to get their blood pressure, there's the top number, the bottom number. Explain physiologically what you are measuring with the top number and what you're measuring with the bottom number.
Right.
Because people just think, well, it's so-and-so over so-and-so, and I know this is supposed to be. So that's the part that I think that people kind of get lost. There's, you said earlier, your blood pressure in your legs are going to be a lot higher than they are in your arms. So what is it that you're looking for? Like what exactly are you measuring?
Right.
Does that make sense?
So the top number is what we call as a systolic blood pressure, and the bottom number is what we call as the diastolic blood pressure.
Right.
The top number is usually the higher one.
Correct.
And it is higher because the heart is pumping blood into the arteries.
Okay.
And the bottom number is the measure of how stiff the arteries are when the heart is relaxing and not pumping as much blood into the blood vessels.
So that's what I want to say. So the top number is the pressure of the blood as it's being pumped into the arteries. And the bottom number is now that the muscles relax, the arteries relax a little bit, that number is going to be lower, has to be lower because of that. So that's the relaxing of the same artery.
Right.
Okay. All right. That's what I was trying to get at with that. And with kids, again, I love this idea, and we're going to find out more. In fact, I have to give a shout out to our students again. We're starting to get a lot of questions here from the audience, but we have Melissa Huddleston and Sean Bala. I don't know if we can get a picture of them, but I didn't say your names at the beginning of the show, but I'm getting all kinds of texts here, questions from the audience, and I wanted to say thank you so much for both of them for being here. This is a question I'm reading cold, but it seems that adults are often, sorry, this is technology. It seems that adults are often the ones suffering from exacerbated heart conditions. What should children do to improve their outcomes for later health problems? So I guess this is kind of that question too, when I was thinking, okay, well, blood pressure being taken as a kid, we can talk about diet, we can talk about if you know a child has heart issues from the family, etc. But just in general, you were talking about obesity. We also have a very high incidence of diabetes in El Paso, and I'd like to kind of bring those two into a child as they're growing up, how to maybe prevent some of the issues or lessen the risk factors that may already be with that child. And I'm just looking this way. If you want to rest, I can throw all that to Dr. Schuster because everything's on this side of me. Dr. Schuster, would you like to take any of that?
Well,
so
obesity is incredibly important in El Paso. When we're talking about blood pressure, for instance, it's kind of unusual to see a very young child with high blood pressure, but we do see it. And when we see, for instance, a 3-year-old with hypertension, high blood pressure, we'll check the heart. We'll check for coarctation of the aorta to make sure that's not the cause. But we'll do the rest of the workup because in the really young kids, if you've got hypertension, we're going to be looking very closely at the kidneys rather than the heart. And but in the older kids, the middle school and high school kids, if they've got hypertension, you can usually count on their BMI, the body mass index, as being way high. And we see that so much, and it's very difficult. We give those kids a chance to lose some weight, and if I just see a directional change, if they've been heavy and they've gone the other way a little bit, they've not gained weight between visits and their weight has actually gone down, I will continue to work with them very hard to see if we can avoid having to use medical treatment.
Good.
On the other hand, if we have an obese patient who comes in 6 weeks, 3 months after their first visit, and their weight's gone up literally 5 to 10 pounds, we complete the workup looking for other causes, but at that point I realize that the patient is not going to lose weight and is probably going to be on high blood pressure medicine for quite a long time.
Goodness.
Until we can fix that. We
Right.
can't fix it now.
Right.
So obesity is incredibly important. Diet is also important. Although I see a lot of patients where the family is convinced they're having heart attacks and chest pain from heart attacks. They're not, okay, almost never. But we do see in kids of 12 years old and 20 years old, if, for instance, we lose a kid in a car wreck, if they go in and look at the aorta, they'll find fatty streaks like you've got in the adults. So working
at that young of age?
Yes, at that young of age. And so if you've got any kind of control, you're going to really try to head that obesity off at the pass if possible.
So this is diet and exercise.
Right.
You know, I know medical community preaches it all the time, but in some part of it's hereditary. But let's take that as a sliver because that is a lot there that
Well, let me tell
Yes.
you one of my most frequent things to say
Yeah.
is, do you know what the best way to have a good cholesterol is?
no.
Choose your parents carefully.
Ah, no kidding.
Okay.
You know, yes.
So heredity is really super important,
It is.
but you can't fix it.
You can't fix it.
So
and
you
you're
work on diet.
Spot on, exactly. So again, and try to talk to what we were talking with Dr. Badugu, if you know, when you know better, do better. You know, if this is something you know, and I was actually looking at the medical students because I was thinking about genetics. And I always tell these guys, man, go into genetics because that's so fascinating. But you can find what your predispositions are, you can find what your risk factors are, and then you can kind of take a pivot and go that way. Speaking about taking a pivot, we do have a question here from the audience. It's cardiac related and it's also COVID related. So I'm going to throw it out to which one of you want to take it. It's up to you. But with now not understanding COVID, but now that there's been more patients that have had COVID that are now also living with long COVID or long haul COVID or what have you, the heart does get affected sometimes. And the question from the audience is, what exactly is happening with COVID patients who are having heart complications that may not have ever had any complications before? And I'm looking at whoever wants to raise their hand or start talking.
Yeah. We're learning more information as we're going into the pandemic and as we're seeing more patients. Luckily for us, children have not been affected as much as adults, and that doesn't mean that children are safe and are not having any effect. One of the common involvement of the heart that we have seen is what we call as inflammation of the heart muscle in itself.
Okay.
It presents as swelling of the heart, and the heart is unable to do its duty, which is pumping blood into the body and into the lungs.
So can I throw a caveat question into there? Again, doing research on the show, there are 3 different types of tissue that the heart contains.
Absolutely.
And so when you're looking at the inflammatory tissues, which ones are the tissues and do you know the question I'm trying to ask?
I am.
Okay,
Yeah,
thank you
I
very
do.
much. Thank
So
you.
what you're referring is to the 3 layers of the heart, which we call as the endocardium, which is the inner layer of the heart that has valves, and the middle layer, which is the myocardium, which is the bulk of the heart muscle in itself, and the outer layer, which is epicardium. And it is covered by what we call as a pericardium, which is like a sac that which the heart sits in. So the myocarditis is the involvement of muscle and inflammation of the muscle.
I see.
And what it does is it impairs the ability of the heart to pump blood, which is what we see as simple as lethargy to what we call as a cardiogenic shock, where children are very sick and they need multiple medications to help help the heart do its job, which is pumping out of blood. And myocarditis is a kind of thing that we've been seeing in some children, unfortunately, with the involvement of COVID. And as I said, luckily, even children with heart defects who have been exposed to COVID, they have been doing okay. But what they also do is carry these viruses and give it to others. So it is all the more important to take extra precautions, use safe social distancing, and when it is not possible to distance yourself socially, wear masks and wash your hands many times, multiple times.
And get under the fingernails. That's what I keep telling people, because you're, when you're at the stores, you're touching this and that and the other, and anyway, it's the small things. When you're doing medical stuff, you read all these things, so you just have to do the mask. But absolutely, and again, it's the idea of underlying conditions. Even if you don't know, you may not know. Just take care of all of that. I want to ask Dr. Schuster, because I think this becomes a question. So I started out the entrance of the program that kids are not just little human beings in the world of treating, especially cardiac issues. And I know that we talked about very, very little babies. And then we're talking, what I'd like to see is how different the heart is as a child versus just growing that person up and being an adult. What's strong, what's least strong, what is a simple heart murmur? Oh, it's a simple heart murmur. I mean, you hear that all the time. What is a heart murmur? And it could be 1,000 different things. So I'd like for you to take it from there. When a pediatrician listens to a 2-year-old's heart, oh, she's got a murmur, and mom's like, what does that mean? Take it from there versus someone who's, again, 50s, 60s, 70s, and then dealing with heart issues.
So adult cardiology, and we're the only ones who call it adult cardiology,
Good point.
is mainly acquired heart disease. There is some congenital heart disease in adults, but it pales in respect to, for instance, coronary artery disease. In pediatric cardiology, what we're dealing with is, to a very large degree, congenital heart disease. Then there's a subset of arrhythmias that we take care of, which adults have arrhythmias too. And then there's acquired heart disease. We do see myocarditis from viruses other than COVID. But right now, of course, we're concentrating on COVID quite a bit.
Right.
Now, El Paso has been pretty lucky so far, and we really have to knock on wood that keeps on going. We really haven't had many children become very, very, very sick. So, and usually, as Dr. Badugu said, it affects the muscle, which means it affects how well your heart squeezes.
Right.
And we can support that up to a point, and then we can actually support that mechanically if we have to. But it's been really low grade here in El Paso so far. Now, as far as heart murmurs go, heart murmur is a noise that we hear with a stethoscope. And we can listen and know what it is a lot of the time. But for instance, as we were talking about, if the EKG is abnormal or the chest x-ray is abnormal, we're going to want to pursue that heart murmur and find out what it is with ultrasound almost always. So heart murmurs are extremely common in kids under 12. The bigger teenagers, you can still find some new ones sometimes.
Interesting.
But, it's kind
And
of
when
like...
you say noise, you're listening for the rushing of blood in and out. So physiologically, when you're listening in your scope with noise, what is it that you're...
Well, so what we basically
the
hear
rushing?
are the two heart sounds. And I hope this doesn't screw things up, but that's about what you should hear when you listen to somebody's heart.
Okay.
And a heart murmur would sound like... And that is the heart murmur.
Gotcha.
And for instance, if it sounds well, we can say, that's a Stills Brewy, don't worry about it.
Oh, there you go.
But the first noise I was making was actually a VSD, a hole in the heart.
Oh my goodness.
So,
Okay.
but
And then
that's
there
what
are valve issues. I was asking specifically. I gave it to my son. I have a mitral valve prolapse, but I also have an arrhythmia. Is it related? We're still not sure. It's benign, it's chronic but benign. My son at 17 had arrhythmia that he lost consciousness. So, you know, he's got a syncope and he's 17, healthy young lad, you know. And so there's these questions like how I would never have known, and you know, ambulance came, the school, I mean, it's just one of those things. So yes, he's got a murmur. Yes, he's got a funny sound. Yes, he's got an irregular heartbeat. And it's just curious to me because everything else checks out. There's not a reason really, but it's just something he has. And that's when I was saying earlier, once you know better, you do better. So he knows, you know, not to like to do a crazy overstretch in class, or he knows if he's starting to feel lightheaded to sit down, or what have you. So I guess I'm asking for parents and teenagers who do have the age to understand and know better. What do you advise parents or kids who, when I say kids, someone over 10, between 10 and 20, because you were kind of looking at that age earlier too, of arrhythmias or of, I don't know, super low blood pressure, for example, that can get faint, you know, when they get dizzy, etc.
Well, so arrhythmias almost always are presenting with symptoms. And those symptoms by far are going to be palpitations. My heart is racing. It's going really, really fast. Now, if somebody faints and there's nothing else, if we have somebody who faints, we really are going to evaluate their heart rhythm as a potential cause for that. And that may be just as simple as an EKG, but we also have monitoring that we can do on kids that we are worried about. We can do a 24-hour EKG. We can do a 30-day EKG. We can do all sorts of more intense looking at somebody's heartbeat. Fainting is always scary.
Yeah.
Especially for families. I have fainted 2.5 times.
In your entire life?
In my entire life.
Wow.
One of those was complete and the other 3 were not. And I preferred the fainting.
Did you really?
Oh yeah, because when you wake up you feel better. And when you're almost fainting,
you're just like, yeah. I'm low blood pressure girl, so I prevent myself from faintings. Again, you know, but
well,
you do
you've
better.
learned to live with it.
Yeah, I've learned to live with very low blood pressure.
Orthostatic hypotension is extremely common. That means your blood pressure drops when you stand up.
Big time. And I love being in the garden. So literally, I planted 2 trees that when I stand up, I just kind of, you know, I surf the wave, hold on to the tree for a while, and then I'm good, you know.
Exactly.
This is great that we're giggling right now because we're kind of at that place in the show where I'd love if you, either one of you, if we haven't talked about something that you'd like to talk about this evening, or if you want to stress something a little bit more that we've talked about already, this is the time to do it because we've got about 10 minutes left before we close.
So, yeah, obviously as Dr. Schuster kind of mentioned earlier on, we cannot choose what we're going to be born with. So the congenital heart diseases is something that it happens because of many reasons that we cannot really control. What we really want to do is control the acquired heart diseases, the high blood pressures and obesities, so that when these kids become adults, their risk of having a stroke or heart attack is much less. And we all have been parents, and we know how it works when we tell a kid, this is what I tell, this is what you do. So I think the best way is to do these things as a family. Eat healthy as a family, do exercise as a family, and the more people that are involved, the more easier it gets for the kids. And we don't want kids to see this as a punishment that they are on a diet. We don't want kids to feel at this point of time especially that they are unable to exercise outside, that they are missing out something. So the family together needs to find exercise-related activities while making it still fun for the kids.
Exactly.
And these kids grow on to become responsible adults, and that's what it sets a cycle. If they become responsible adults, they'll teach their kids to be responsible in terms of eating, in terms of exercising, and as a whole, if this cycle kind of repeats itself, we can control the incidence of acquired heart defects, strokes, heart attacks, and other complications that could be avoided.
See, and then strokes for a child, that just doesn't even compute to me.
Right.
You know, it just doesn't compute, but obviously it happens.
Right.
Yes, Dr. Schuster?
We didn't used to diagnose strokes in kids. We just, they'd have a major brain event and we wouldn't call it a stroke. Nowadays, we are acknowledging that the kids are having strokes. Most of it is either from congenital malformations or coagulation problems. The blood
like
clots
hemorrhagic
too
or-
easily and stuff like that.
Okay.
And so we've identified some of those. I mean, we've got some patients with, was it Monday, Tuesday, Thursday, Friday? Anyhow. And those kids, adults might be on heparin injections. Kids might be at least on a baby aspirin once a day and things like that.
Wow. Okay.
I did want to bring up that we are seeing way too many people being afraid of the hospital when they really need the hospital.
Right.
Especially, we've got numbers from New York because they went through it in such a degree. But there were so many people who were not going to the hospital because they were afraid of getting COVID when they're having heart attacks and strokes. And they said,
Just go to the hospital. Yeah.
yes, you need to go to the hospital. And, but on the other hand, if a family calls the pediatrician and says, Grandma had COVID and now the kid's acting like he's sick, should they take him to the doctor? Should they take him to the hospital? Well, the things that should put you over at the hospital are major disruptions in your essential bodily functions. And mainly what we're talking about at this time is respiratory. If you're having trouble breathing, you have to be seen. Now, in kids, we're seeing a lot more GI symptoms, generally speaking, with a lot of vomiting and diarrhea. And if you're dehydrated and you're unable to keep water down, that's a reason as a kid, even though you have COVID, you're going to go to the hospital.
Right.
Now, at the hospitals, if you're coming in with respiratory or GI, you're going to get a COVID test. Anybody admitted to El Paso Children's has had a COVID test. And we're trying to make sure that we keep the kids who need to be in the hospital. And if you're not that sick, you may have a positive COVID test, but if you're
Doing okay.
you're playing Fortnite, you probably don't need to be in the hospital.
Right. If you're playing Fortnite, you can tell you guys are pediatric guys. So true. And I wanted to stress that actually prior to ending the show too, because again, the medical community, you guys are both here. You're dealing with people that have COVID all day, every day. You're in rooms and buildings with people that have COVID all day, every day, but you're taking the precautions. You're washing, you're wearing your masks, you're making sure other people do the same. And I don't know if either one of you wants to throw out something to give guts to the person who is wearing the mask, but the person in front of them is not, and to ask somebody else to wear their mask. Have you had that situation too? Because it's like, well, what if they're going to get mad, or I'm taking away their rights? I want to bring it up because I feel like it's such an issue. You hear about it on several news programs. You hear about it in shows. You hear jokes about it on, and now sitcoms that are doing COVID time talking. What would you say to someone who, you're meeting a real estate agent, for example, and he's not wearing a mask, and you're trying to buy a house, and they're just, all over the place. Do you have the right to ask him to wear a mask?
Absolutely. Yeah, luckily in clinics and in the hospitals, we are seeing families who are aware of the healthcare situation, so they are actually being very proactive in putting the masks on. And even the kids that are coming to the hospitals or clinics, they're putting the masks on. Luckily, we are not seeing any resistance in those kind of situations. But if somebody in the situations that you're mentioning, it's not about you, it's about the other person. You have every right to wear your mask or not, but you don't have a right to transmit your viruses to others. So it's a little selfish not to wear masks and infect or potentially infect others.
Right.
And many of these kids or people that are around you, they could be on immunosuppressive medications, they could have underlying health conditions, and you could potentially put them in danger, life-threatening situations. And it is not a big ask to cover your face.
Yeah, they're available everywhere. I remember years and years ago, Mike, it's 23 years ago, we were working on the smoking ordinance, and there was a gentleman at City Council that said, my right to swing my fist stops when it hits your face.
Right.
And I think about that often when it comes to these masks. My right not to wear a mask stops when I'm in your breathing space.
Right.
So I look at it that way, so that may or may not be an answer. I want to say we don't have enough time for another question, but I do want to throw out some information here. So again, Melissa Huddleston and Sean Bala, thank you so much for all of your questions. You may have seen me referring to my phone several times, so all the questions are very social distance. In the old days, they would sneak over here in their socks and hand me the cards, but no more, and you also see a plexiglass between the two of them. I like to show that. Because again, this is serious stuff that we're dealing with. And again, this is a medical program, and you just need to get that across. So when you're outside, if you don't need to go somewhere, just don't. Just hold off for a while. We are in a spike time right now. Again, we are in the middle of a presidential run for election, and the debate that started at 7 o'clock on many of the other stations will be in full starting here right after this program. So in about another minute and a half, you'll be able to start watching that too. We're just asking everybody to get out and vote. We're not telling you who to vote for, obviously. We are doing the El Paso Physician one more time during the month of October. And with me this evening, I want to say a big thank you to the El Paso Children's Hospital. Again, the doors opened in 2012, and since then, over 85% of the kids that were leaving town to get treatment are now able to stay in town. Dr. Maduga earlier said that we still have a good 85% for certain procedures that are going elsewhere. That number was brought up because little by little that is starting to get to be a smaller number because there really are doctors coming in and technologies and all kinds of great things that are happening. Thank you again to Texas Tech Paula Foster School of Medicine, and a huge thank you to the El Paso County Medical Society, who's been working tirelessly trying to get PPP out to the doctors, and they're going to be providing masks for the doctors on the show, and they've been doing this show forever, just nonstop. So thank you so much to the El Paso County Medical Society. I'm Catherine Berg, and you've been watching the El Paso Physician.